Good afternoon, everybody. My name is George Jacobson, and I am the project administrator for the Targeted Investments Program, one of Access's ongoing programs.
Thank you. Thank you. My name is David Bridge. I'm the Director of Housing Programs for Access. I oversee our approximately 3,000 units of permanent supportive housing for persons with behavioral health issues.
All right, so I'll start us off with a high-level overview, just orienting us to Medicaid here in Arizona, and then we'll talk about our most recent endeavors with integration. And we're going to end out with a little bit of a panel discussion with George and David today. So just to level set about Access, we are the largest insurer in Arizona. We cover over 2 million individuals, close to 2.2 at this point, and we cover more than 50% of the births in Arizona and 2/3 of nursing facility days. We use federal, state, and county funds to provide the healthcare coverage that we do for the state's Medicaid population. We have over 100,000 registered providers with Access, and then we also make our payments to our 15 contracted health plans that are responsible for the majority of the care delivered by the Medicaid system. Almost 90% of the Medicaid system in Arizona is through managed care organizations that we often call MCOs. So just to level set also on our enrollment, as you can imagine, over the course of the last year through the public health emergency, we've seen a significant increase in enrollment. Part of that is due to more people qualifying for Medicaid, but also that maintenance of effort requirement that we're currently under due to the Families First Coronavirus Act. And so really looking at not being able to disenroll anyone unless they move out of state, pass away, or disenroll by their own desire. And so again, as you can see, can you hear me? I'm sorry, I'm hearing some feedback that my sound is coming crackled. Okay.
David, I wonder, could you try muting? Maybe it might be one of us.
I was muted. I'm not sure.
All right. Well, Leslie, we will keep trying and see if you can hear me clearer. But as you can see, over the course of over the past year, our enrollment has increased to above 2.2 million. So I'm just going to level set as well with some recent integration efforts. For those of you that have been in Arizona a while, you would remember the Division of Behavioral Health Services, and that was separate and had a separate place in the system than Medicaid. And so there was that movement to move DBHS, the Division of Behavioral Health Services, into the state Medicaid agency. And so a large portion of my team actually came from that merger. And then moving forward, we've done a lot of work to ensure at the plan level there's integration. So plans serving a variety of populations cover both the physical health and behavioral health benefits for members, and they're responsible for provider networks covering all of that as well, and making sure that we treat the entire individual and we don't treat behavioral health and physical health separately. And then the providers. You're going to hear from George a little bit more today, but really there's been a lot of work done at the provider level to allow for integrated care at that point of service. And then the last piece of integration where we're really starting to dive in now and have for a year or so is looking at integration with the whole person. And so not looking at healthcare in a vacuum of just physical health and behavioral health, but everything that can impact your health. And so we'll talk a little bit more about that. And so that has to lead us into our whole person care initiative. So what impacts your health? What impacts how you deal with the healthcare you receive if you seek healthcare and your outcomes overall? And that is not just what you can get through a doctor or a psychiatrist or any provider. And so really looking at the person as an individual beyond just the healthcare they receive, looking at healthy behaviors, the physical environment they live in, socioeconomic factors, access to education, access to employment, and then access to housing. So we're going to talk today about some of our efforts to really bridge onto that next venture of healthcare and integration and looking at addressing social determinants of health. So we launched our WPCI, Whole Person Care Initiative, in November of 2019. Leading up to that, we've done a lot of work really looking at our provider network, assessing for social determinants of health, making referrals, documenting as such, using Z codes. And then we did a lot of stakeholder engagement around what is it that everyone's feeling we need to focus on, and what are some things that we're doing really well at that we should expand on. And so the 5 things that you see on the slide are really what we were honed in on. So housing, access to housing. If you receive the greatest healthcare in the world, if you don't have access to housing, that can limit your success with that. Also employment, criminal justice, transportation, and social isolation. And of course, that social isolation was feedback we had from the community prior to a pandemic, which left many of us very isolated. And then lastly, our last endeavor was with the closed loop referral system. So some people call it a closed loop referral system, some people call it social services referral system, but basically, if you identify that you have any type of need for, let's say, I'm going to give an example of food. I identify that I need some food, and whatever provider I'm working with is going to work to send me somewhere where I can access food. How do they know if I'm able to obtain it? How do they know if that food bank has the supply for me? How do they know what happens? All they're doing is kind of giving a recommendation. And so that closed loop referral system kind of leans on technology to help us do the referrals, but close that loop. Did I go pick up my box? Do I have access to food now? And so that is an endeavor that we took on with our Health Information Exchange, Health Current, and they awarded recently to NowPal for that technology piece. And so looking at that, we have the vendor selection and contracting. We have implementation planning, which is the stage that we're in right now. There's going to be some pilot sites soon. And then general rollout for this will be in fall of 2021. So that's some of the work that we've been looking at in the next step of integration. So again, looking at the whole person beyond what we generically think in that physical and behavioral health realm. So now we're using our waiver. And so what we're going to talk about today, both David and George, is something through the waiver. The waiver demonstration, AHCCCS submits for renewal every 5 years. We just recently submitted a renewal. And so we are in negotiations with CMS currently on that. But beyond that, we're working on an amendment to submit hopefully this week as well. And so David will talk about that. And again, through our public comment period for our waiver demonstration, we had a lot of feedback leading us back to housing and what we can do in that realm. And so the waiver is a wonderful process for the community to come together with AHCCCS on what will meet Arizona's needs. And so outside of what we do through the state plan, the waiver allows us some more flexibility, and we negotiate that, and it's subject to CMS approval. And so David, I'm going to turn it to you to talk about our housing and health opportunities, conveniently named H2O demonstration proposal. David.
Thank you, Dana. Thank you all for the opportunity to present today. One of the exciting things about this and the Whole Person Care Initiative is that AHCCCS has been in the housing space for a number of years. Back to the integration that Dana was speaking to between behavioral health and healthcare, AHCCCS for the last 20 or more years has had a stock of housing for its members who are determined seriously mentally ill. With support, and we use a permanent supportive housing model that contemplates both housing subsidies to assist members who are homeless or with low incomes, as well as to wraparound services for those members. And again, those wraparound services are often can be provided through Medicaid reimbursable services that we have available through previous amendment efforts. The H2O demonstration proposal we're talking about today is really an attempt to fill those gaps and really make sure that we're using housing as a tool to address that whole person care strategy. Really, there's 3 key strategies here, or 3 key goals that we have for this H2O proposal. Obviously, the first one is to increase the health and well-being and outcomes for our target populations, which we'll talk a little bit about. Secondly, just where the Arizona healthcare cost containment system. So again, with Medicaid, there's always an effort to maintain high qualities of service, but also be fiscally responsible and make sure that we're reducing the cost of care wherever possible. And we'll talk a little bit about how we've demonstrated that housing does significantly reduce healthcare costs, back to that whole person care vision. And then finally, we want to use this strategy to help support larger community efforts to reduce homelessness and maintain housing stability. Again, housing has been demonstrated on the homeless side that the provision of permanent supportive housing, especially for individuals who are chronically homeless, has literally been documented to basically end people's homelessness, especially if you wrap the right services around individuals. So again, knowing that there's such an intersection between homelessness and behavioral health, we want to make sure that our housing units and our housing strategies are supporting those larger efforts around homelessness. Basically, there's 3 sub-strategies that are included in our demonstration waiver. The first one is to strengthen homeless and outreach service engagement. So one of the big challenges that we have on the housing side is, on the Medicare side, the Medicaid side, is that Medicaid doesn't directly fund housing units. Again, the dollars that we have for housing units come through our non-Title 19 state dollars that are awarded through the legislature, allocated through the legislature. Generally, one thing to know is that CMS or Medicaid doesn't generally provide housing, long-term permanent supportive housing subsidies. So the strategies here are really focused on those wraparound services to assist members in securing housing and meeting their needs. Again, utilizing other mainstream resources like our Access Housing funds or Section 8 grants or other programs in the community, and using the Medicaid dollars to provide the wraparound services that are critical. So the first one is this idea of strengthening outreach and service engagement. This would include increasing the ability of outreach teams to go onto the street, into the community, meet people where they are, including in-reach into hospitals and other institutional settings, including jails or prisons, to help with service coordination and discharges. Again, not only for members, access members who may be unengaged due to their homelessness or their current behavioral health situation, but also individuals who are eligible that may not be enrolled yet for those same reasons. The second strategy is for supportive, for what we call housing funding for members who are homeless or at risk of homelessness. This wouldn't be permanent supportive housing vouchers, but there may be some precedent that we could provide short-term or transitional term housing assistance in the form of maybe like congregate settings or hotel settings, or even what we would call rapid rehousing, where we could pay rent for a set number of months after someone is transitioned from a inpatient or institutional setting. So if you've been discharged from a hospital, you still need some ongoing support. We don't want to send you back to the homeless system. You know, if we could put you in an apartment for a couple months, at the end of that time, you could either take the rent yourself, or maybe in that period of time, we could assess your ability to live independently and move into a permanent supportive housing voucher. But again, there may be some precedent that CMS would fund some of that, some of those transitional housing costs. Also in this area would be paying for some of those incidental costs that can be barriers for people moving into housing. Again, for our SMI members now, we have the ability to pay move-in deposits, application fees, utility turn-ons, and assistance with those types of things. The idea would be expanding this beyond our SMI population to our larger at-risk home and homeless population. That would also include some eviction prevention services as well. And then the final strategy would be increasing our Medicaid wraparound services and support. So again, right now, if you are determined seriously mentally ill, or you're in our GMSU, general mental health or substance use disorder population, you may be eligible for wraparound services. And when I say wraparound services, this would be things like home-based case management, life skills, socialization and connection to community, crisis management, substance abuse supports. A lot of these can be provided in the person's housing setting and be focused on maintaining that person's housing stability as a platform for their larger goals. The idea would be to expand these to other at-risk homeless populations, again, which we'll talk about in a minute. The final piece of this, and this is the big piece, is to expand that target population. Again, many of these services are currently available for persons who are determined seriously mentally ill through our state funds. Again, we don't have enough resources through our state funds, so these will also, expanding these to Medicaid services will expand their ability to cover our current SMI and general mental health population. But more importantly, we want to expand it to these other at-risk populations that may be underserved right now in our system, in the homeless system. Again, continuing to focus on persons with serious mental illness or with substance abuse mental health or substance abuse needs, but also looking at individuals who are considered high risk or high cost. So again, people who are frequently in the system, into crisis systems, hospitalization, things like that. Again, people with repeated avoidable emergency room visits or crisis utilization. Again, looking at people with chronic health conditions, in addition to mental health conditions. Looking at persons with high risk of homelessness based on institutional discharge. Again, people that we know will end up in the homeless system if we don't provide some type of housing support. Again, looking at other at-risk populations, including pregnant or postpartum women. Looking at young adults between the ages of 18 and 24 who are transferring out of foster care. And then finally, some services for all All-Tex members who may be living in group homes or community settings, but with some of these housing supports may be able to transition into their own independent living. Those are the key elements of the program. And again, these are based on significant work we've done in the community, lots of feedback from all kinds of stakeholders at every level, and really go back to the idea that, you know, housing is healthcare, and that the provision of the right housing with the right supports can significantly improve people's ability to manage not only their independent living, but also address their healthcare needs and their behavioral healthcare needs in a much more efficient way, as all the research is documented. With that, I'll turn it back over to Dana and George.
Well, good afternoon, everybody. Again, my name is George Jacobson, and I have the privilege of administering the Target Investments Program. Really important program, as Dana alluded to earlier, that encompasses access strategy to integrate care at the point of care. So the Target Investments Program is a 5-year program, and a combination of funding sources totaling $300 million over that 5 years. It was implemented in 2017, and we are in the 5th and final year, and we'll be ending the program this September. And basically, the goals and the focus of the program is supporting providers to transition to more integrated and coordinated care, reducing the fragmentation that many access members and frankly many folks in the general community experience when navigating between physical health services and behavioral health services. Our particular focus is on access members who have chronic health conditions and or behavioral health or need behavioral health care as well. The ability to reduce that fragmentation improves the efficiency of the delivery system, and with our ultimate goal of really improving health outcomes for the folks that are being served. So what I'm here to talk to you about mostly today is our renewal proposal to CMS as part of the 1115 waiver that Dana and David discussed a moment ago. And we want to extend the program through 2026, through the next 5 years, next 5-year waiver period. And we submitted the initial request back in December. There's been additional amendments submitted. In fact, we'll be submitting another amendment in another month or so, describing what we have in mind to CMS. The concept paper that we submitted is publicly posted and available for folks to see. And the main effort with the renewal is that we've done some great things with the initial Target Investments Program. There's been a real transformation of care for those providers that have participated in the program, but there are providers that did not participate when we started the program back in 2017 for a variety of reasons. And many have expressed interest in taking advantage and utilizing the support and resources through the program to move their practices and organizations to more integrated models. So the goals for the Target Investments 2.0 program, as we're talking about it, it's another shorthand for the renewal, is to sustain the efforts of the current participants, those that have been participating beginning in 2017, and I'll talk more about that in a moment. As I said, we want to expand the opportunity for new providers to participate. And in line with the discussion that Dana and David have started, really want to encompass a whole person care perspective. And that means more fully and thoroughly having structure in the program to address health-related social risk factors, the things that have been mentioned: housing, food insecurity, social isolation, those sorts of things. And again, as Dana's mentioned, this all aligns with Access's strategic plan to more fully integrate care for Access members. So the way we're proposing to structure the 2.0 program is to break it out into two cohorts. And the first cohort, which we're referring to as the extension cohort, and these would be the folks that participated in the initial program and are graduating, so to speak, from that program. And they would be continuing with some of the work and initiatives that they started in 1.0, but adding to that another layer that more fully addresses the whole person care needs of the members they're serving, and doing that through addressing those social risk factors through a variety of ways. One of which is the support of utilizing the closed loop referral system that Dana talked about earlier, the system that that enables communication between providers and social service agencies. The expansion cohort would be that group of participants who did not participate before, and we would continue with them to have that primary focus on integration of behavioral and physical health services, but not to the exclusion of addressing social risk factors and SDOH as well. But they would be that cohort would be modeled pretty much on what we did with the first phase of the program. So what we're proposing to CMS is funding over $250, over the 5-year period of $250 million. And that includes both state and federal match. And I seem to have lost my slide. There we go. And again, that would be through a variety of state and federal sources. And just to recap and be clear, like the first program, the renewal would provide resources, funding to participating providers that meet the milestones and goals of the program that support behavioral health, physical health integration, and more fully addressing the social needs of the patients and clients they're serving. So with that, I think I'll turn it back over to Dana.
All right, well, thank you, both of you. And we're going to turn this into more of a discussion panel with the two of you. It's been a very, very busy year between the waiver renewal, the amendments, the flexibilities to address COVID-19, et cetera. But if you reflect back and you think mostly in the alignment with housing and targeted investment, what do you think is the greatest accomplishment to date that you've had here at Arizona?
I can start that off. I really think that the impact, and it may be kind of an obvious answer, but I think it's the impact on the Access members' well-being and lives, and really have been gratified by the feedback we get from the participating providers about how the Access members they serve express appreciation for having those more coordinated services, for having the ability to access behavioral health services, where they receive physical health services, and that the kind of the concept that we introduced through the Target Investments Program back in 2017 has not only been embraced by the participating providers, but also by and more importantly, by the access members they serve.
Yeah, I would second George's comment. I think the thing that's been most impressive to me around our providers and our members is that, through this crisis, which has really hit the housing industry, we've seen all the information about housing moratoriums, and, there's a lot of worry going into the COVID with the economic impact on individuals that, we would have a lot of people displaced. And I can say that for the most part, we didn't really see a lot of that in our current housing network, in the current access housing network. So just being able to maintain housing for those 3,000 members and maintaining that platform for them to address these larger issues. And then I think the second piece is COVID's really shown us the value of this collaboration, because of the crisis. Sometimes a crisis, you don't want to waste a crisis. And it's really given us an opportunity to work with our homeless providers better, working with our MCOs, our REBAs, and our ACC plans closer. We started doing data sharing with a number of different new partners to try to better identify the needs of members, both housing and otherwise. So really just, again, moving to that integrated care model, and really it's kind of COVID's forced us to bring together a lot of new stakeholders and partnerships. So besides just our ability to maintain our current effort in this crisis, also the ability to start working more collaboratively and creatively with our partners has been successful.
Great. So thinking back on that reflection and definitely not wasting a crisis and taking all of our lessons learned, what would be your words of wisdom for a provider community to embrace the next step in integration? Because I think, every provider is at a different stage, right? And so thinking around stakeholders and the resources for this process, what would your thoughts be?
Well, I think what I've observed and what I've learned from others involved with the program is that it's very evolutionary. The process we're involved with is a long progression, a long journey, but it's important to continue to take steps and that really continue to kind of make the North Star looking at the care that is provided with and of course, as the name implies, the whole person, that you really can't fragment the person. We're not a series of body parts, and we really can't divorce the emotional well-being and mental health well-being from the physical well-being. And I think what happens as providers and others in the community begin to work in a more integrated process and system, that becomes real evident quickly. And I think it's frankly a source of satisfaction to providers to be able to address the needs of the access members they're serving more fully. And in many cases, I think they just need some support and a little bit of guidance on how to best do that.
Just quickly, I noticed Suzanne Feister had added a question about how we're currently working with the homeless shelters and in collaboration. Just real quickly to speak on it from an access housing standpoint, a couple different ways. One, we have some of our discretionary funding currently committed through our REBAs to provide behavioral health coordination positions at the Human Services Campus in Maricopa County, which allow us to, better identify and prioritize some of our members of behavioral health through their coordinated entry system. Similarly, we've been working with DES to provide some homeless funding with access collaboration to identify to fill some of the gaps in our system. Some that H2O hopefully will provide long-term support for. So through some of the CARES Act funds, we worked with DES and we were able to get some additional funding for transitional housing, some outreach and some shelter supports. And then a big piece of what we're doing right now in that coordination is data sharing. So through COVID, on the crisis basis, we were able to start doing some COVID data sharing around HMIS individuals who had demonstrated, either COVID positiveness or being symptomatic. We actually were able to blend those records with our portal information, our eligibility portal information, and give that information back to the MCOs, back to the ACC plans and the REBAs and their providers, so that they could do care coordination around those individuals. And we immediately identified people who had, walked out of births, behavioral health residential facilities, and they were found and reconnected to service. We got new people enrolled that may have been underserved or had been enrolled but not connected with a provider. So we really started, again, back to my point about kind of new partnerships, we really started demonstrating some of those abilities to coordinate and work together. And really that's my lesson or my takeaway or my advice would be, no one of us has all the answers to these problems. Not everybody's a Medicaid patient, right? Not every homeless person is in a shelter. Not everybody goes through the jails, but yet we all have a piece of the needs of these members. And so it really is this collaboration and this really willingness to look beyond our silos and work with other systems of care. Again, try to understand them culturally, and then really rethinking all of our processes from the bottom line up. When we talk about whole person care, that's a new type of assessment. It's not just, what cough and what prescription I'm going to give you for your illness. I need to ask questions about your housing status or your food security or, some of these broader things. And not all of our providers have that experience or that background or are used to asking those kind of questions. A lot of times those things are considered off limits or may not be, they may not be comfortable talking, or may not have resources, so they don't feel comfortable asking those questions if they don't have a solution. And again, that's true of other systems of care as well. The homeless system may not know what healthcare questions to ask to get people to the right levels of care. So it really is that, really rethinking all of our processes in this larger integrated context. And then secondly, really working with those other partners to, reduce the barriers between our systems so that our members get a more complete level of care.
Yeah, Dana, if I could touch on that collaboration theme that David mentioned a little bit from the target investment perspective, a couple of things that have really been great to see as the program developed. We established a learning collaborative for those providers that are participating in the program, and they have a chance to share with each other and learn from each other. And that has just been really well embraced and really appreciated. And certainly something that we intend to continue if we get the program renewed. And the other piece of collaboration that's been interesting to see is, and David mentioned silos, there traditionally have been silos between the behavioral health provider community and the physical health provider community. And as the integration process has evolved and unfolded over the period of the program, we've seen those silos break down and that more collaborative approach to meeting the individual's healthcare needs, whether they be physical and or behavioral health. So that really has been, I think, a hallmark of what we've seen with the Target Investments Program as well.
Great, lots of themes of collaboration and using these opportunities to really all come together with the focus being on the member, what we're here for. So I'm going to open it up to the audience for questions as well. I have a couple more questions for George and David already in my head, but if you have questions as the audience, we open it up to you. I know we only had one in the queue and David got to Suzanne, but if anyone else has any questions or thoughts. All right, well, while I wait for one to pop up, I'm going to ask you guys another one. So as we continue to evolve our system and address more than that physical health and behavioral health and looking at all of those items and how we've had a huge impact on members, how does that impact the cost curve and keeping that mindfulness of the quality care that we want to ensure our members get?
Yeah, and David's going to have a lot more to talk about, I think, in his area. So I'll just say a couple of words about that. But it just seems like whether it's adequately addressing behavioral health needs or social needs, the net result is that the person doesn't receive the care they need when they need it. And typically that results in more expensive overall care. And the classic example, of course, is the person who utilizes the emergency department at a hospital for all types of healthcare issues, be they minor or otherwise, and even sometimes for social reasons. And we've all heard stories about persons that go to the hospital because they haven't had enough to eat, but obviously that's not an efficient way to meet those needs. So I think it's doing well by doing right is really what we're shooting for. So, but David, I'm sure you have a lot more to say about that.
Yeah. So, this is one of the areas where we have solutions. I mean, that's the exciting thing is, and we were talking about a lot of social issues, we don't even know where to start, right? They're so complex and huge. But, in the case of housing, we have a long history of demonstration projects and pilots across the country that have demonstrated the efficacy and the cost savings and the programmatic benefits of permanent supportive housing as a model, especially for people with acute needs. One thing that was exciting this year is access in preparing for this H2O demonstration waiver. We actually polled, all of our REBAs had done their own evaluations of their housing programs, and that through the access program, and all of them had demonstrated various levels of success in reducing costs and improving health outcomes. So most of the huge savings that we had seen were related to decreases in crisis utilization, decreases in hospitalizations and inpatient stays, reductions in like emergency transportation or ambulances, as part of that crisis savings. Some increases in cost for primary care, which is actually a positive because that's significantly cheaper, than the alternative crisis response. When people are going to the emergency room, as George pointed out, for their basic needs or their basic healthcare needs, which is what's been demonstrated in a lot of homeless situations. Access this year looked at over 3,000 individuals who had been in housing for at least a year period, and we looked at their costs 6 months prior to moving into housing and their costs 6 months. This is their medical costs and utilization 6 months after leaving housing. It was pretty amazing. Basically, we documented and validated what some of the other REBAs had shown. Basically, we documented over a $5,000 a month saving per client in reduced costs. Again, the vast majority of those savings were in 30% reduction in emergency room visits, 44% reduction in inpatient admissions, so hospitalization. Really impressive one, an 89% reduction in behavioral health residential facility admissions. So again, many of these individuals can live independently with the right supports in housing, don't need those higher levels of care if they have the right housing and supports. Overall, there was a 45% reduction in the cost of care for these members. And again, most of these are chronically homeless individuals who have been documented as seriously mentally ill. So again, it's kind of our stereotypical homeless population. So, in addition to just, you can assume those are also improved health outcomes, right? The fewer times you have to go to the emergency room is probably better. The fewer times you have to be in a residential or inpatient facility is probably better. But we've also started to see data around, reductions in substance abuse behaviors, reduction in mental health crisis behaviors, or those types of crises that lead to evictions and things like that. So, the evidence is all there that housing really is a solution or is a critical component to that overall, not just the whole person care, but that integrated healthcare approach. So, like I said, the key now is how do we make sure we have enough housing and services? Because I think that's something we often forget is that, just putting somebody in an apartment by themselves with a behavioral health and a substance use need is not a recipe for success. It's also that integrated wraparound services, the behavioral health and healthcare services. So, we're starting to, we can demonstrate those programmatic outcomes as well. So really, really positive outcomes there.
Great. Thank you, both of you, for that insight. So I'm still not seeing any questions. So I'm going to give it just a minute and see if people want to put any questions or thoughts in the Q&A. And perhaps while we're waiting, I can ask another. So I always like to close out anything that we do, just kind of going back and circling back to our why and why we do the work that we do, why we get creative and innovative with healthcare, and why we're constantly just pushing to the next level. And then that comes back to the member and the member experience of their healthcare and ultimately their life. And so I'm sure you have countless stories, both of you, whether from the housing arena or from targeted investments. And so wanted to know if you could high level share a story about the impact.
David, why don't you go first? I've been stealing the limelight here.
Yeah, Dana's right. You constantly hear these quotes from permanent housing, and usually they start with something like, this individual we never thought, been on the street for years, had been written off by any number of systems of care, including the healthcare system in some cases, their family and everything. We did an outreach pilot this past year, a little over a year ago, and this story just devastated me when and it reflected the power of what you can do when you have this integrated, coordinated system and everybody's working together for the same goal. As part of this project, we had done outreach in downtown Phoenix to try to find the most acute homeless individuals in downtown, try to apply these integrated principles and solutions. We had coordinated outreach from local behavioral health providers. We had City of Phoenix on board. We had Maricopa County. We had housing vouchers provided by our PHA. So just a real testament to the collaboration. But one of the cases they identified on outreach was a gentleman who had been on the street, I believe, over 5 years. He was legally blind on the street, and it was a progressive process that, because he was just trying to get by day to day, he had never, taken the time to get take care of that. He was just trying to survive. And when they finally engaged him, he was legally blind. They were able to put him, back to Suzanne's point, they were able to put him in a transitional shelter for a few months while they were working on a long-term housing solution that was provided by Access and by a housing authority. In that time of engagement, the behavioral health specialists were able to work with them. They actually got him in an appointment to get his eye surgery, to do the surgery to restore his eyesight. In doing that, they realized they couldn't do the surgery because he had high blood pressure, because he hadn't been, back to the social determinants, hadn't been maintaining a healthy diet, hadn't been maintaining, wellness regimes. And so they couldn't do the surgery. So again, having him in shelter, having him in a safe place, they were able to, get him back on a diet, get him back onto like a healthy regimen, bring his blood pressure down, get him on medications. He was able to get the surgeries, and within the 4 months it took him to get housed, he had regained his eyesight. And the touching part, back to the human connection piece, is that he actually went and reintroduced himself to all of his care workers because he had never seen them when they were actually working with them on the street. So the human part of the story is just, like I said, devastating, but it shows that, seemingly insurmountable barriers and obstacles and, health and behavioral health and all the other conditions can be resolved when you have a coordinated group of people working together for a common outcome, focused on the client's needs, with reducing every barrier possible to get people to where they need to be. And it's the same reason you and I succeed, that we have those support systems. And when just about anybody has those support systems and the right housing, to put people in, we can all succeed. And I think that's what always gives me hope in the work that we do. And making that available for more people is always my goal, our goal.
Great. Thank you, David. I want to make sure we do get to the question that did come up in the chat. And the question is, do you see any new innovations such as telehealth that will help in the next 5 years to address the social determinants of health through the work of Access? And so I can say a few things about telehealth. George, feel free to chime in. Long before the pandemic and the public health emergency, we had a very robust telehealth policy. It was actually launched of 10/1 of 19. And so we were already moving in that zone to really allow telehealth and incentivize telehealth in our system. Obviously, that was paramount in our success to our pathway this last year, and really making sure that members continued care, had access to care. And we've received robust feedback from the community, the provider community, and the member community that they really want to see telehealth options continue on. And so really working to look at our options moving forward of what we will do coming out of this pandemic. And again, if you haven't already seen it, the current telephonic code set and telehealth code set is all listed on our COVID FAQs of what's currently open. But again, our telehealth policy is very robust, and I do think absolutely it has shown tremendous impact on the individual staying engaged. And then we've also had feedback from a lot of members that that is a new way of engagement for them, and possibly a preferred way of engagement. And so look forward to all of those opportunities for individuals that maybe don't like going to an office or have a lifestyle or a schedule that really kind of inhibits some of those opportunities. And then also, of course, looking to our rural and frontier communities and how to address their needs there as well. But George, do you have anything you want to weigh in on telehealth?
Yeah, just a couple of brief comments. One is that, again, just to echo what Dana was saying, we've had a lot of feedback from the target investment participants about how critical the availability of telehealth has been, over the last year or so, and that we certainly are building it into the renewal that we're designing right now, and making sure that and kind of rethinking, frankly, where we can encompass or embrace telehealth to really just improve the access, small a, of our members to services. I don't know how much time we have, but I wanted to just acknowledge, Dana, if it's okay. Leslie Maxwell made a point about success with patients getting diabetes under control, and yeah, that's kind of a classic example of members with a chronic health condition who many times may also have a behavioral health condition, and just having those two services and points of care working collaboratively. So thank you for that comment, Leslie.
Yeah, just real quick on the housing side and telehealth, that was one of the major challenges and concerns at the beginning of the COVID period. It was already a hard housing market when that hit, but again, a lot of the housing authorities shut down their offices to do briefings. A lot of our care providers who were used to doing home-based visits had to switch protocols. A lot of our outreach teams that were out on the street, engaging people on the street, had to change their practices and protocols. So it really did disrupt a lot. Just a lot of testament to the creativity of our providers and our network to use telehealth in ways to overcome those gaps. And then again, as Dana and George, I think, both pointed out, in some cases, that was the preferred mechanism, that some people actually preferred not having to knock on the door every day for a home visit. They preferred being able to just do a quick check-in. One of the exciting things in some of these current federal relief plans and funds is there may be an opportunity to get more connected devices in the hands of members, so that we can expand that capacity, especially in some of those rural and frontier areas like Dana mentioned, where, it's almost impossible to do daily driving visits and things like that, but where telehealth may really cover some of those and shorten those geographic barriers we face.
All right, well, I think we are at time, so I will just like to wrap up by thanking both of you, George and David, for having this discussion today and continuing our discussion here in Arizona about how the Medicaid system in Arizona can contribute to that ongoing evolution of integrated healthcare, and really keeping a mindful watch on the whole person care initiative. Well, thank you everyone for spending part of your afternoon with us. We greatly appreciate it.